Good afternoon. I am Fahad Faruqi. I'm a medical oncologist and hematologist here at Northwestern Medicine. Today I'm going to be talking about chemotherapy-related toxicities and more specifically focusing on nausea, hair loss, as well as fertility issues. Those are some of the more common things that come up in questions I get from patients. I am here recording from the LivingWell Cancer Center. The LivingWell Center in Geneva actually provides more than 100 different services to patients and families free of charge for those who are impacted by cancer. So it's a great resource for our patients. If you have any questions, please feel free to comment below with those, and I will do my best to answer them at the end of this talk. So, whenever I see patients, there are a few common themes and questions that come up, especially patients of mine who are about to start chemotherapy. And a lot of patients have concerns about nausea, a lot of patients have concerns about hair loss, and a lot of patients have concerns about fertility, especially our younger patients who are still in their childbearing years. So I thought I would take some time today to talk about those things. Of course, chemotherapy has a lot of other potential side effects and toxicities where, that we could spend a lot more time on, but we'll focus on these three issues first. So I'm going to start off with talking about nausea and vomiting a little bit. I know that many of you who are watching and many of our cancer patients who come in have received information about dealing with chemotherapy-associated nausea and vomiting. I want to sort of talk about two things on that front and two important things to understand. So one question I often get from patients, and one thing I often hear from patients, is a concern that, well, I had a friend who went through chemotherapy, or I had a family member who went through chemotherapy, and they had a lot of issues with nausea, they had a lot of issues with vomiting, and they had a lot of gastrointestinal issues. And patients are often hesitant to start chemotherapy for that reason. One thing that I want to address is that there are hundreds of different types of chemotherapy drugs, and some of them cause more nausea than others. So chemotherapy that your friend or your relative may have received may be very different from what you received, and the chance of nausea with the chemotherapy drug you receive may be very different than the chance and risk of nausea with the chemotherapy drug somebody else receives. And then secondly, every patient reacts to chemo differently, and so the journey that you take with chemo might be very different than somebody else who gets the exact same chemo regimen. So it's very important to understand that because we try to individualize therapy as much as possible based on the treatment you're receiving as well as how you respond to that treatment. That being said, when we look at patients who are getting chemo, the first thing I look at is, when it comes to nausea, is what type of chemotherapy are they getting? There are certain chemotherapies that have a very high risk of nausea if we do nothing to prevent it, and other chemotherapy regimens that have a very low risk, where even if we did nothing, the chance somebody would get nausea is low. So for those chemotherapy regimens, we don't have to do too much to prevent nausea, but for chemo regimens where we are dealing with potentially high risk of nausea, we give everybody pre-medication prior to chemo to prevent any issues. And what type of pre-medications people get is really dependent on the chemotherapy type, but there are basically three main types of preventative or prophylactic, as we call them, medications that can prevent nausea. A couple of them are IVs, but they can also be given orally. For example, one of them is a drug called Emend, which is often used with a drug called Aloxi, or sometimes Zofran. And these two drugs together are often given before chemotherapy to help prevent nausea. The way these chemotherapy drugs work is they actually prevent the signaling mechanism within the brain that says that, okay, you need to throw up now. And so these are actually pretty effective medications to help prevent nausea, especially the first few days after receiving chemotherapy. We often also give steroid medications for the first 2 to 3 days after chemotherapy to prevent nausea as well. So these three kind of classes of medication combined are very powerful in preventing acute or short-term nausea from chemotherapy. a lot of patients ask me about, well, if I do have breakthrough nausea, what can I do? Despite these medications, if you have nausea, what are the options? And there are a lot of options that are both medication related and non-medication related. So, we always send our patients home with at least one, but usually more than one anti-nausea medication for breakthrough nausea in case people have it. So, we have many different tools in our armament to treat nausea, breakthrough nausea if people have it. As far as home remedies that can help. This is a very common question that I get. So, the data on this is very mixed, and so a lot of this research is sort of still early, and a lot of the research is still ongoing on this. But there are a couple points here to make. One is that there have been some studies done looking at ginger, actually, to look at ginger as a possible treatment for nausea. And those studies have been mixed. There are some studies that say ginger is really helpful in treating nausea in chemotherapy patients, and other studies that say maybe it's not that helpful. In my experience, it depends on the patient, and some patients say it's extremely helpful, and medications didn't do anything for them, and somehow drinking like ginger tea did. And if that's the case, great. I think it's worth trying, certainly. Ginger is a fairly benign spice. It doesn't really have any interactions with chemotherapy, so taking ginger or ginger extract or ginger tea is not a bad idea. To see, hey, if it helps you, great. Another thing that I speak from experience is cardamom. Cardamom is a spice that I have recommended to some of my patients who've really had nausea, and for one reason or another, medications were not either working for them, or there were interactions, and so they couldn't take them. So I've recommended that, and for some patients it has helped. And again, cardamom is just a spice. It's not a hot spice, so it sort of has almost a menthol type flavor. And some patients say that it does provide them, chewing on that does provide them with relief. So, the other thing that I always tell all of my patients, and this is regardless of nausea or not, but it does help prevent nausea, is just adequate hydration. So when you're getting chemotherapy, more so than other times, it's really important to keep hydrated. So what that means is, drinking at least, I would say, 60 to 80 ounces of water every day. I always tell my patients coffee does not count. Coffee actually is negative because it can dehydrate you. But water, Gatorade, a Pedialyte, those sort of things do count. So, keeping hydrated is really, really important when it comes to preventing nausea, because dehydration can just pile on top of other things to make that worse. So happy to answer any questions about that if people have. But, the other thing that I would like to talk about is hair loss. So a lot of my patients are concerned about that. And so addressing that issue, I think, is very important. Whenever I have patients who are going to get chemotherapy that is going to cause hair loss, I always do address that with them. There are some important things to know about this. So number one, not every chemotherapy causes hair loss. So you'll see a very common theme here, which is that chemotherapy can have a wide array of side effects, and just like not every chemotherapy causes nausea and vomiting, not every chemo causes hair loss. So there are some chemo regimens that cause no hair loss or very minimal hair loss, and there are other chemo regimens that essentially cause hair loss every single time. Almost 100% of the time, we can pretty much be certain the patient will lose their hair eventually. So that's important to know. And when I discuss this with my patients, I tell them, you will likely lose your hair, and so just be prepared for that. When people do lose their hair, it's usually not immediate. It usually is a delayed side effect. So if you got your chemotherapy today, you probably wouldn't notice any significant hair loss for 2 to 3 weeks, and then it will kind of come out pretty rapidly. So that's important to know. The second thing to know about this is that even if we did nothing for hair loss, which is often what we do, is nothing, because is that the hair loss is reversible pretty much all the time. It is very rare for chemotherapy to cause irreversible hair loss. It can happen, but it's rare. And the reason is because the chemotherapy it affects the hair follicles because they are fast dividing, and chemotherapy, unfortunately, is not very targeted sometimes. So we give it through an IV, whether through an intravenous port or a peripheral IV, and when we give chemotherapy, it goes everywhere that the blood goes. That hopefully also includes cancer cells, and so the way chemotherapy kills cancer cells is that those cells are fast dividing, so it can kill them off. But any normal cells in our bodies that are also fast dividing also can be affected by chemotherapy, and that includes our hair follicle cells. So, chemotherapy can be toxic to hair follicle cells for that reason, and that causes hair loss. Thankfully, the stem cells that produce our hair, that actually are responsible for regenerating those hair follicles, don't divide all that fast. They're pretty, they don't grow that fast. So they are not as susceptible to chemotherapy, and once someone is done with chemotherapy, those stem cells can then regenerate the hair follicle, and patients then eventually, over the course of a few weeks to a few months after being done with chemo, start growing their hair again. So that's important to note. But hair loss is a really significant issue for a lot of people. It's a matter of appearance and a matter of dignity for a lot of patients, and patients have wanted to know what they can do to prevent hair loss. So there have been studies done on this, and probably the biggest sort of breakthrough on this that has happened in the last several years is something called cold caps. So a lot of you may have heard about these, but these are essentially cooling caps that patients are fitted with on top of their head. Literally, it's a cap that's infused with a coolant that is fitted to a patient's scalp, and it cools their scalp down to a certain temperature. And the idea behind that is if you cool down the scalp, the blood vessels within the scalp constrict. And this is a normal response. If you like put ice on your hand, the blood vessels within your skin are going to constrict where the ice is, and because it's trying to preserve heat from escaping the body. So blood vessels have this reflexive constrictive mechanism when they're exposed to cold, and so the blood flow in that region is reduced. So if you have a cold scalp and the blood vessels there are constricted, you're going to have reduced blood flow to the hair follicles in the scalp. And if you think about it, well, if chemotherapy can only go where blood goes, and the blood isn't really getting to the scalp as much as it was before, that means the hair follicles, the scalp and the hair follicles are going to have less exposure to chemotherapy, and therefore the chances of that hair falling out is going to be reduced. There have been actually studies, clinical trials looking at this, and it has shown that cold caps are pretty effective. About 50 to 60% of women keep most of their hair if they use a cold cap. Depending on the study, it can be a little more or a little less. So it's not 100% effective, but for women who want to do everything they want, and I'm saying women here for a reason because this is mostly approved in breast cancer patients. There is some data in other cancers, but mostly in breast cancer patients. For patients who really want to keep their hair and do everything they can, cold caps are an option. There are some drawbacks logistically to it. You have to come to chemotherapy a little bit beforehand in order to get fitted with a cap for every infusion. You have to wear the cap throughout the infusion, and then you have to wear the cap usually for at least a couple hours after the infusion. And so, the entire infusion process is a little bit longer due to that. But for patients who want to do everything they can, it is definitely a very reasonable option and something we offer here at the Cancer Center. The final thing I want to talk about is fertility. So this is something that unfortunately we have a lot of young patients, especially young breast cancer patients that I see, but also young patients with sarcoma, among other cancers that I see, who are still in their childbearing years. So whenever I have a young patient who's premenopausal, meaning their ovaries are still functioning and therefore they still have the potential to have children, I always talk with those patients about, about fertility. if and some patients do say, "Yep, I'm not done with childbearing yet. I would like to have the option of having more children," and in that case, I usually refer those patients to reproductive endocrinologists for fertility preservation. But here, I do want to talk about sort of the big options in fertility and what they are, which are really important to know about. The two most well-studied fertility preservation techniques in cancer patients is harvesting eggs and freezing them, and then or harvesting eggs, fertilizing them, converting them into embryos, and then freezing them for future use once a female patient is ready to have a child. These are the two most well-studied techniques. Also, when you freeze an egg or you freeze an embryo, they can be frozen and still viable for a very long time, not just a few months, but many years. So it is a very good option. And the way it's usually done is you go to a reproductive endocrinologist, they give some hormonal medications to stimulate the ovaries in order for them to produce follicles, germinal center follicles, that then are harvested through a minimally invasive procedure. Those follicles have eggs in them, and those eggs can then either be frozen as just unfertilized eggs, or they can be actually fertilized with sperm and then converted into embryos and then frozen at that stage. This is all done prior to starting chemotherapy. And usually we are able to, unless somebody has cancer that is so aggressive that it really needs to be treated within a few days, we usually have time for women to undergo this procedure. So that is generally the most well-accepted option for preservation. One other question I often get is something about suppressing the ovaries in order to preserve fertility. So another option for fertility preservation that is being studied and is not quite standard of care yet is actually shutting down the ovaries with hormonal therapy in order to protect them from the effects of chemotherapy. So, the idea here is that if chemotherapy is only toxic to dividing cells, if you shut down the ovaries with hormonal medications and they're not the ovarian follicles that have the eggs in them are not dividing anymore, that should protect them against chemo. This has been studied, and the results are mixed. So there are some studies that say this definitely does produce some ovarian protective effects, meaning that women who are premenopausal, after then they're done with chemotherapy, they're still premenopausal, they're still having periods, meaning their ovaries are still functioning. However, the evidence is not there that this has actually led to increased number of pregnancies. That the idea here in preserving fertility is eventually that women are still able to have children, female patients are still able to have children, and so that data is just not there yet. That this has actually led to improved outcomes in fertility rates and pregnancy rates and then deliveries. So that is still something that is an active area of research. But one thing that I can say is still a good adjunct to egg and embryo preservation. So, sometimes what can happen is, a female patient undergoes egg harvesting, and it turns out that there were just a few eggs that were harvested, and not every egg will be viable. So it is possible that, those few eggs are all non-viable, but then we cannot wait for a second round of egg harvesting because that would take too long and we need to start chemotherapy. So in that situation, maybe we would suppress the ovarian function with hormonal medications as an adjunct to protect the ovaries, just in case the egg harvesting was not successful. So it can be like a supplemental or adjunct to the more well-proven ways of preserving fertility. I should also say on this, just like with hair loss, just like with nausea and vomiting, the risk of infertility with chemotherapy is highly variable on the type of chemotherapy people get. There are certain chemotherapies that are higher risk, and there are certain chemotherapies that are much lower risk. So this is also something that is not necessarily pertinent to everyone. It is more pertinent to patients with who are getting certain types of chemotherapy. So with that, I'm going to stop. I'm happy to answer any questions anybody may have.
We have one that just came in. I think you just answered it, but let me just say it again. Does chemo in general cause infertility, even if not listed as a side effect?
Yeah, so that is an excellent question, and as I just said, the answer really is it depends on the type of chemotherapy. There are certain chemotherapies that have a very low risk of infertility, and other chemotherapy regimens that have a higher risk of infertility. So a good example of this is patients who have Hodgkin's lymphoma. There are actually, let me give you maybe a more pertinent example. I'm not sure who's joining in, but breast cancer might be a more pertinent example. Patients who are getting breast cancer, if you are getting adriamycin cyclophosphamide for breast cancer, which a lot of patients who have early stage breast cancer do get, that has, based on some studies, a much higher risk of infertility than somebody who's getting Taxol. Oftentimes patients get both. But really, if somebody's getting adriamycin cyclophosphamide, we would be much more cognizant of the fertility issues than if somebody was just getting Taxol alone.
Another question that came in previously, and that is, are there any special shampoos after hair loss happens? Is there anything that you recommend for growth? Is there anything that works or not really?
Yeah, that's a great question. So there are some evidence that hair loss shampoos like Rogaine, for example, while it doesn't prevent hair loss, actually may speeden up the recovery process. So if somebody really wants to speeden up that process, that may not be, that could be a potential option for those patients.
More questions have come in. Emily is asking, how does chemotherapy cause premature menopause?
Yeah, so that's an excellent question. So, I'm going to go back to sort of the basic fundamental way chemotherapy works, which is really important, I think, for patients to understand is chemotherapy, conventional chemotherapy, given through an IV, the way it works is that it targets fast dividing cells in our body. So the fastest dividing cells in a cancer patient are the cancer cells. And that's how chemotherapy kills off and is toxic to cancer cells, because it's targeting those cells because they're fast dividing. Unfortunately, those are not the only cells in our body that divide fast. Our hair cells, as I mentioned earlier, divide fast. Some cells in our gut divide pretty fast as well. And in women, in female patients, the ovarian follicles that contain eggs also divide fairly fast, which is why women, generally speaking, have regular periods every 4 weeks. That's the turnover rate for the ovarian follicles. So they're dividing pretty fast, and therefore they are potentially affected by the chemotherapy. There are these cells within the ovaries called granulosa cells that are affected, and those are very important in the ovarian follicles maturing and eventually causing ovulation. And those granulosa cells divide fairly fast. So the chemotherapy can actually be toxic to those cells and kill those cells off. And if you kill off enough of those follicles, those granulosa cells, you're pretty much speeding up the process of menopause. And eventually, there may just not be enough follicles left that contain viable eggs, and eventually the ovaries stop functioning. So it's pretty much speeding up the process that happens naturally in all female patients who eventually become menopausal. Is it depletes the reserve of ovarian follicles that have viable eggs, and then that causes ovarian failure.
Another question came in, and the answer may be Rogaine, but I'm not sure. I am taking tamoxifen for breast cancer treatment. While it is not causing complete hair loss as chemo may, it is causing hair thinning.
Yeah.
Is there anything I can do to strengthen my hair?
Yeah, so I think that is a conversation that a patient should have with her provider. If that provider is me, I would be happy to see her back in the clinic and talk about different options. There is when Rogaine may be an option. There might be other hair shampoos that may be an option, but there are other potential topical treatments we could talk about. Tamoxifen-induced hair thinning is certainly not uncommon, but there is no medical sort of treatment for it. Certainly, there's some shampoos like Rogaine that may help.